Good morning, everybody. We're going to get started. Good. So we have no slides this morning, so don't be staring at the screen. Instead, you're going to be staring at Stephen Berger, who it's really a great pleasure to have him here. You know, I don't know how many of you have heard of this concept of groupthink. Groupthink is when people get together and there are no dissenting voices at the table, and people make horrible mistakes. The most famous of those stories is about the Challenger disaster, where NASA would get together to plan this, incredible mission that cost billions of dollars to put together. And there were voices at the table who kept saying, but who were quiet and who weren't listened to, who kept saying that the O-rings that had supported the rocket boosters had never been tested in the conditions that the system that were present on the day of the launch, and nobody really listened to them. And as a result, terrible things happened. Stephen Berger, to me, is one of those voices who, thankfully, has been invited to many tables and at times of tremendous crisis, both in the city's financial crisis decades ago and more recently in the healthcare crisis. He has more than 5 decades of experience in financial services, in higher education, and in the public sector. He's served as chief executive officer in both private and public organizations, board members, corporate director, private and equity investor, and as a university professor. He got involved in healthcare in the 1970s when he was the director of the New York State Study Commission on New York City. He did a major analysis of Health and Hospitals Corporation. He went on to serve as New York State's Social Service Commissioner and was responsible for the whole Medicaid program. 25 years later, he was drafted by Governor Pataki and Governor Cuomo to re-engage with the healthcare system. He chaired the government's task force on healthcare reform in 2003 to 2005, which laid out a template for health system reform. He went on to chair the New York State Commission on Healthcare Facilities in the 21st Century, which has now come to be known as the Berger Commission. And if you Google it, you can't find it in any other way except to put the name Berger in there, and you'll get the results of the commission, which was really a way of looking at New York State and the kinds of transformations in the institutions in New York State that needed to take place in order to right-size the system and make it more rational. Following that, he's been a member of Governor Cuomo's Medicaid redesign team. He chaired the Health System Redesign Group, which proposed a restructuring of Brooklyn's hospitals and primary care facilities, and he presently serves as a member of the DSRIP Program Project Approval and Oversight Panel and the state's Value-Based Pricing Committee. He's also on the board of United Hospital Fund and chairman of their program committee. Unless you think that we haven't been the recipients of some of his influence, one of the major recommendations of the Berger Commission was the putting together under one corporate parent Kingston and Benedictine hospitals, which are now known as the Health Alliance. And another was the suggestion that North General Hospital become part of the Mount Sinai system, which didn't happen for a variety of reasons, which I won't go into at the moment, but fortunately didn't happen because the hospital actually closed and we became the recipient of all of their ambulatory care services, which now were morphed into our Harlem Health Center. So with great pleasure and at the suggestion of many, we invite Stephen Berger to give us a sense of what he thinks is going to happen and a little historical perspective on what's happening in healthcare in New York City. Stephen.
Thank you very much, Neil. Neil convinced me to come and talk because you guys actually practice medicine. You actually deal with patients and you deal with those problems, and I enjoy that since most of the time I deal with other folks who mess with you. And what I like to do is take a moment to go back a little bit in time, because we're going to end this discussion both in questions and in discussion, and Dr. Kalman will interrupt me when I talk for too long, and talk about some of the changes that are taking place now. But to understand them, I got to back up, because we're talking about changing very deeply embedded infrastructure. And, you know, I spent a lot of my time on transportation. I ran the Port Authority. I was on the board of the MTA. You know, you think about infrastructure, you think about the city, you go underneath, you got the pipes and all this. The infrastructure in the health system is just as deep, just as old, just as rigid, and just as resistant to change. And a lot of the stuff which is on the back end of what we talked about, disrupt and value-based pricing and all the rest, is an effort to sort of change that. We're changing 25 Second Avenue subways all at the same time around the state. Let me go back just to try to frame this a little bit. In 1946, the federal, right after the war, the country's health system, and I put that in quotes for a second because we're going to talk about definition of what a health system is. The country's health system was in real decay. Now, what that real discussion was that the hospitals in the country were in very bad shape. And so the federal government in 1946 passed something called the Hill-Burton Act. And the Hill-Burton Act was a major step because what it did was it provided funding, both grants and loans, for the construction of hospitals around the United States. And in a sense, if you want to look at the infrastructure, I start at that point because there are a bunch of things in that bill and what happened that create the infrastructure that we're all living with now. First, the federal government got involved, put up money. Remember, we're going to follow money through all this. It's flow of funds. Put up money, and there were several caveats. One was the money, they put up a third of the money. The other two-thirds had to come from states and local governments. Okay? So you're going to have three levels of governments involved. Flow of funds was going to drive health delivery creation, i.e. hospitals. And there were two other sort of characteristics of the bill that are important. One, which was ignored for 20 years, that the whole, behind this, you had to provide necessary free care for people who are eligible for it. Never defined who was eligible. Nobody did it for 20 years. But it was in the bill. And the other piece that was in the bill is that the hospitals that were created had to be viable. Okay, you guys stop for a second. We didn't have Medicare. We're going to get to Medicare in a minute. We didn't have Medicaid. We're going to get to that in a minute. But they had to be viable, which means that by definition, almost impossible to put them in areas that were basically populated by poor people. So this is the history. Okay, here is, let me reshape that history. The history is, after the war, the United States gets involved in healthcare, and they define healthcare as building hospitals. So you're going to have a brick and mortar system that's going to come out of this. Second, it's not a simple program. You have three layers of government. And you have three layers of government, you got 6 levels of bureaucracy. 6 levels of government activity, because each layer of government has 2. It has the executive branch, which is the regulator and it's supposed to shape policy, and then you have the legislature, which has got its fingers all over it because it's politics and it's money. So you got, I don't know, somebody here, you know, have a calculator? So you got 3 layers, each of them interacting, each of them open for pressure from groups which are anxious to get money and to change things. That is where sort of this starts. We've got this today. So you have to understand that. And we'll talk about different influences and different political influences, but you have to understand the kind of system that Hill-Burton created. And the other part, which is 75 years of this, is until recently, and we've started, the notion of healthcare was the notion of building hospitals. And we're now trying to actually change that, but that's what it was. And it was that for the politicians, it was that for the, it was that for communities, it was that in general discussion. So that's a piece of how that started. Secondly, the second piece that we have to remember, we're going to follow the flow of funds, is that with the establishment, with the establishment in the mid-'60s of the support programs, Medicare and Medicaid, you now created a new flow of funds into the system. And by then, the government was actually trying to push people to take care of, starting to think about the underserved populations. But you now created a new flow of funds into the healthcare system. And so what you now had was, in addition to the pattern I described, you now have a system of, which we have in this country, of multiple payers that are involved in the flow of funds into the delivery of care. Okay, so we got a lot of government involved, we got different layers of government, we got to focus on capital investment, and we have multiple players putting money into the system. At the same time, because you guys, wherever you are all in New York, okay, New York ends up doing something that makes it totally different from the rest of the country, okay? We did not secede. But what we did in healthcare was create a system which had one major difference in the rest of the country. And that in 1965, the governor of the state of New York, Nelson Rockefeller, was trying to pass something called Article 28. Everybody heard of Article 28? It's before 29, it's after 29. Anyway, so, but what he wanted to do was to put in place the CON procedure, Certificate of Need procedures, and in order to do it in a political system, the governor needed the legislature. In order to get the legislature, the governor needed Cardinal Spellman, right? You don't know who Cardinal Spellman was, but you can guess what his job was. Anyway, in this instance, right, Cardinal Spellman's interest was protecting the Catholic hospital system. And Cardinal Spellman was very worried about the danger that he saw was that what was happening in other parts of the country were that for-profit hospitals, corporate hospitals, with shareholders, were growing and building, and he wanted to keep them out of New York to protect the Catholic hospital system. So the deal that was made was, in exchange for the church agreeing and delivering their legislators. I know that doesn't happen, I'm just making that up, right? For delivering their legislators, okay, we get Article 28, we got the CON, but publicly owned corporations could not own hospitals in the acute care system. Now, we'll talk, we may never get, but part of that was, that created basically, we had a mercantile, we had a protectionist system which blocked certain things from happening, including things which might have created in our acute care system a more competitive, better organized, and more efficient health delivery system. But you can read my report about that. But the fact of the matter that we created a separate system in New York. You know, by the way, how much good it did the Catholic hospital system. That trade, that's one of the worst trades, right? Anyway, but what we now had in New York, and what the progress was to build a system that was our system, a regulated system, large flows of funds coming into the system and flowing through a fee-for-service network. The whole country is fee-for-service, but a fee-for-service network that, by definition, meant that we were improving and creating a sick care system as opposed to a health care system. Because, and this is not to criticize people in healthcare or anywhere else, but if the flow of funds, this is not sort of a high-level religious organization, with monks who only eat bowls of rice on Thursday. You have a right to assume that people who are in the delivery of care are going to be influenced and shaped by the flow of funds. But the flow of funds is a fee-for-service system, which, and leaving aside the abuses that have taken place, but naturally meant that the reimbursement meant that it was the wheel, more people went through the turnstile, the more money came into the institution. And so that was the system that we created. Now, I'm going to add to that another piece, and it's an important piece, and it's an important and delicate, and I say that in all seriousness. I don't mean delicate politically. It is delicate politically, but it's also delicate and has to be dealt with intelligently. Given the growth and funding and extent of the healthcare system that was built in New York, the workforce in the healthcare system became a very important part of the economic stability of the state of New York. As certain kinds of jobs disappeared, as manufacturing jobs disappeared, that workforce, whether it was a workforce in the acute care system or the workforce in the home health care system, that workforce became a very important part of the lifeblood of the communities of the state of New York. So, and that also became a very important part of the political decision-making process. Because you can argue from whichever purist point you want, and I can do any of them, but the fact of the matter is you had to take into account the fact that legislators in Albany, and I'm going to come back to that in a minute, that legislators in Albany or in Springfield or in Sacramento had to balance the issues of health care delivery and workforce and budget problems and budget costs. And that was a delicate balance in which, in all, particularly in New York, to be honest about it, the workforce issues tended to have the greater weight. And if you added to that the fact that by creating a system where healthcare was defined as hospital care, that was something which became embedded in the minds of people, and particularly, but not solely, in the minds of safety net communities where there were high levels of minorities, low level, work problems, low levels of income. The hospital, for both the workforce impact and for its presence, was conceived and seen as the center of people's health care, and it was, and is pretty much to this day. And as many of you know, that was also because the downstairs of the hospital, I like to divide the hospitals into upstairs and downstairs. And most people, by the way, when they think of the healthcare system and why it's important in their communities, think of downstairs. Downstairs, the emergency room, downstairs are the clinics, downstairs where they go, when somebody is sick, when the kid is sick. And so the downstairs became the hospital, and the hospital therefore became an integral part of the community. And so you ended up with a system, a political framework in which a combination of workforce and people's understanding of what they needed from a healthcare point of view came together to support this network of bricks and mortar that had been created over time. Now, the funny thing about bricks and mortar is that it don't always correspond to either healthcare needs, discoveries, changes, both in communities, in knowledge, and in intervention. And in fact, the other part is that this bricks and mortar thing in New York, by the way, had three pieces. Understand this. We're in one of those pieces here today, those of us in New York. Folks outside are not. We are in a part of the academic medical framework network of the state of New York. That is one chunk. These are not-for-profit institutions governed by boards, okay? They're charitable institutions governed by boards of good-natured leaders. Most of them are clueless about healthcare, but they do God's work and they give money, so they're wonderful. But that's the academic institutions. The second chunk were community hospitals. And the third part were true public hospitals, like the Health and Hospital Corporation of New York, Nassau, Erie County Medical Center, which were basically publicly owned and run. HHC at one point before it morphed into what it is now, which is the city hospitals. So you had three sorts of hospital systems, and each of them had different drivers. Okay, and if you look at them, the public hospitals actually were the closely tied to the political system. But the others also ended up in different ways being tied to the political system. But because of the changes that were actually taking place in healthcare, what we really ended up with 15 years ago, actually it was before that, but we ended up with, and it became painful 15 years ago, was a vast excess of beds in the hospital system. In 1960, I had to write this down. By the way, I don't have slides, and I'm too old for that crap, so I just gotta hope I can put it on the index cards. In 1983, the occupancy rate of the acute care system in New York State was 82.8%. By 2004, when I got drafted back into looking at the healthcare system, it was down to 63%. And what that meant was a couple of things. The excess capacity in the acute care system, much of it in safety net communities, but not all, but much of it in the safety net communities, resulted in a couple of things. First, the fact of the matter was the quality of care wasn't that good in many of these institutions. There's some people in this room who may remember, but when I was Social Services Commissioner, I walked through several hospitals and a couple in the Bronx. And I got to tell you, there was nothing in there that explained to me why all those people on gurneys in the hall really were being taken care of, and a variety of other things. Now, by the way, we still have a couple of those institutions in the state of New York today. Some of them I visited not that long ago. Secondly, you got unnecessary utilization because you were in a fee-for-service system. And if you were in a community, and if you had a patient who could actually pay, i.e. Medicaid, for example, or Medicare, or and in the safety net communities, you had fewer and fewer third-party insurance patients. You all know that. But, the number of people who went from the emergency room upstairs into the beds, and we've got statistics on but you did it because it was cash flow. And you could argue, and you could scream, and you could yell, but this was survival. But it was spending large amounts of money that were necessary. You had duplication of service. You had effectively a medical arms race with people, and they're still doing it, putting into place services that they should not be putting into. They didn't have the proper capacity to do it, and it should not be done in some of these small community hospitals. And in effect, the safety net was in real danger because many of those hospitals could not survive. And in fact, they didn't, because during that same 20-year period, as I remember, between 1983 and 2004, 70 hospitals in the state of New York closed, went bankrupt and closed, and 63 nursing homes went bankrupt and closed. And most of them, many of them, maybe all of them, tended to be in safety net communities because the reimbursement could not support the institutions, and the institutions were actually not needed. What was needed was what I call downstairs, and what was not needed was the whole facility. We didn't know how to get there. The other piece of this that one has to understand is up until about 10 years ago, what would happen in New York was that the hospitals, the community, the academic medical centers were good schnorrers also. Everybody know what a schnorrer is? They're beggars. The academic medical centers knew how to do it also. They did it with a little more class. Guys on the board had better suits. But the fact of the matter is that the way many of these hospitals survived, even though 70 closed, was that at the end of the year, there was a regular pilgrimage to Albany to meet with the Department of Health And that pilgrimage, when I was there, we came to social, and that pilgrimage was, we're broke, we're going to have to close. And the pilgrimage consisted of union members, and it consisted of members of the board, it consisted of community people, and amazingly, at the end of the year, the state in its budget would provide funds that were used to bail out many of the hospitals. Problem, of course, was that you reached a point where the Medicaid budget of the state of New York is a third of the budget. It was, at that point, it was about $46 billion. Now it's over $50 billion. And the other part of it that was very tough was that, and it's less so now, was that in the original structure of Medicaid, the federal government paid 50%. The state paid 50%. But in New York, the state was the state and the local governments. So the state paid 25%, and the local governments paid 25%. And effectively, in many counties outside New York City, in places where some of your folks are, the entire local county budget effectively was going on the Medicaid side. You had no money for transportation. Schools were different funding sources. You had no money for transportation. You couldn't fix roads. And the county executives and the county legislators were hysterical. And they should have been, because they had a variety of services to provide. And the state, over time, started picking up more of it, but it was still an enormous pressure on the budget. And so you now have, that's why you have the three levels involved, you now have three levels of government, where you have the executive branch doing one thing. By the way, the notion that legislators, that whether it's the Congress on Medicare and rates and coverage, or that the state members of the state legislature, many of whom are my good friends, those who are still there, the notion that these guys are setting rates for service, right, and deciding what services will be delivered is really as bizarre as anything in Winnie the Pooh. All right, just everybody should understand how crazy that is. But that's what we got. Okay, so they go up at the end of the year and they fight and they get extra dollars. But even with that, 70 hospitals closed, and more were going to have to close. And the problem, of course, was that the whole system was cockeyed. All right, it was cockeyed because first of all, you were trying to balance fundamental economic workforce issues with a healthcare system. And therefore, whether you liked it or not, you really couldn't deal with the serious questions of healthcare delivery. Because when you touched into them, whether it was workforce or communities, you could not explain why you had to make changes. And under the old basic system that we had, it did not make a lot of sense. So, in 2004, a governor who I did not know, of a party I was not a part of, stumbled on it. He was in the middle of a disaster. He asked me to chair a little task force. I chaired a little task force. It turned into the commission. But the fact of the matter was that there was enormous pressure to find a way to protect and save the system. And that first round, the main thrust of the first round was based on a theory which said, look, we're not going to take any money out of the healthcare system. This is not an effort to balance the budget or to fund something. But the answer is we need more money inside the healthcare system, but we really need to focus it. And the main problem is to focus it in communities where you have people at risk. And we got to figure out how to explain it, but the fact of the matter is some of those hospitals should not be open. They shouldn't be open for quality reasons. They shouldn't be open because they're way under on utilization. They shouldn't be open because there are alternatives. And figuring out alternatives, by the way, upstate and downstate is very different. There are different kinds of problems. But those resources ought to go into protecting the institutions that we can protect. And that was what the commission that I headed tried to do. Now, one of the problems with that approach is that, at best, it is a short-term solution. And it is a short-term solution for two reasons. The first reason is that if you look at the cost of providing service, You do not have, and I think we're at the upper payment level in New York State now. You do not have rates under Medicare or Medicaid which can, in fact, support the cost level that we have in many parts of our healthcare system. All right? I mean, you can argue about it one way or another, but the fact of the matter is the people who work in the healthcare system, particularly unionized workers, actually have decent salaries, and they have decent jobs, and they can support a family. And by the way, I would argue that it's not their wages that are the issue, but it's the fringe benefits, which are at the 65% level, which is double what it is in the rest of the country. But that's for another time. But the fact of the matter is, you could save some money by closing hospitals that were unnecessary. You could increase utilization in hospitals that were remaining. But it wasn't going to be enough for a long-term solution, because the long-term solution meant we had to go into the infrastructure and change everybody's behavior. Good luck. And we're trying to do that right now. And what do I mean by that? You have to move to a different system of how you approach healthcare, i.e., you have to move to a healthcare system instead of just to a sick care system. You can't get rid of the sick care system. You need it very much. But you've got to change the approach and the attitude, which says we are going to take the next 10 years and change, 15 years, Neil, I don't know, and change how people think about healthcare. And when I say people, I mean everybody. I mean providers who deliver service. I mean communities which are worried about their families. I mean everybody has to change how we think about healthcare service. And by that, I mean we have to move from a system which has fundamentally supported bricks and mortar, an acute care system, to a system which is built around, just to be very blunt, a preventive health primary care system. Because we underfunded primary care. You know, some of you are old enough and some of you are too young to remember some of the rounds with the federal government where, by the way, the feds had the same problem. So what would they do? Either one year they either cut things like, well, we're going to reduce what we're reimbursing for imaging. Okay? No more imaging. People should take drawings. Okay. All right. Oh, the easiest thing to do is reduce what you pay docs. You know, reduce what you pay the guys in the office and in the clinics. That's easy, you know, easy. So what we had to do was shift our approach and begin to think about how we change healthcare delivery. And this is why I started this discussion by talking about infrastructure, all right? It is easier, I must tell you, dig the Second Avenue subway than it is to change all this behavior. And one of the reasons it is hard to do is that it is not simple, other than to say we want to help you and pay you more and encourage you to reduce the fee-for-service and the turnstile approach and to take care of people in a comprehensive way and in a way that gives them better care. I mean, you know all this stuff. It ain't easy to do that for a couple of reasons. First of all people ain't the same people. There are different levels of difficulty, different levels of comorbidity. There are different problems in different kinds of communities. And we do not have, by the way, just so we all understand it, you know, we don't always have cooperative patients. You might have noticed that, all right? Anyway, so it means we're behavior changing, and then what we say is, we are changing behavior and we are going to compensate you for delivering quality outcomes in a new format and in a new structure, but we're not quite sure how to define the quality yet, and we're not quite sure how we're going to reimburse you or how much or how we're going to measure, but that's where we're going. That's where we are going. Now, this is obviously sort of the way you have to go, but understand what that means and what's taking place. If you're going to go to forms of bundled payments or capitated payments. Payments in which you pay somebody for taking care of the total cost of a hip replacement, okay? Or at the far end, a total cost for a 300,000 people you're responsible for, pooled dollars, and you have total responsibility. And if you really keep them out of the hospital, you can't make them sicker, okay? You're really not supposed to kill them either. If you can actually make them healthier and keep them out of the hospital, because just think about Medicare Part A and Part B, all the money's in a hospital, and bupkis, that's a small amount of money, is for the docs. The fact of the matter is, if you can reduce the in-hospital costs by keeping people healthier, you, as a member of a clinic, an organization, a practitioner, you will make more money by actually doing what you swore you were going to do, because we're now going to help you do it. And by the way, there are things that are happening. We don't have time to talk about technology. You guys know about it. There are lots of things you can do today you couldn't do 20 years ago, but you've got to start thinking about that. And then you have to figure out how to compensate. And how you build systems so you can compensate people, how you make value-based pricing really something real. And we're going to, by the way, just so we understand, we're going to make lots of mistakes on the way. Just everybody understand that. There are going to be mistakes, there are going to be screw-ups, auditors are going to jump up and down, legislators are going to scream, and all the rest. But that is a process of change that is going to have to take place. But making those changes, it's going to happen in the midst of all of the pressures that I talked about before being pushed upon the decision-making systems. And those are political systems, those are institutional systems. You know, a couple of quick examples. When people are on the boards of community hospitals, there are two things going on inside them. One is the good works they do, and they do. And particularly if you're in a community hospital board, it is not always easy. The other part is I don't know, the Yiddish word is nachas, how you feel, how wonderful it is for the good works you are doing. Well, darling, the good works you should be doing is closing the goddamn hospital, keeping open a clinic, and moving the bed someplace else. But you're not on a board anymore. And then you have other kinds of, there are other human issues involved in these kinds of changes. And all this is taking place inside a world in which several things are happening. The first, and in New York, we are going through two things at the same time. We are going through massive consolidation of the large healthcare systems. And in this case, they are really healthcare systems because it starts with their hospitals, but they're more than hospitals, okay? They're independent practitioners, they're doctors' practices, there are a variety of things, and what you've got is sort of empire growth. We're at one empire right here, okay? But they're not the only empire, right? There's one that just changed its name so they can't be held accountable. I understand why they're doing it. But so there are a variety of, there are empires growing, and they're becoming more diverse, and they're including other kinds of delivery service into their structure. And the other thing, at the same time, you're having, I don't know the right way, it's the opposite of, you're having this spread. You're having a spread of urgent care clinics. You're having a spread of clinic networks. You're having growth in freestanding outpatient clinics. You're moving into different, actually mostly still moving into middle-class communities because that's where you have the insurance and all the rest. But it's going to move across. So you have both things taking place at the same time while we are trying to change people's attitudes about how we're going to actually deliver service. And how, when in fact you look, I think, 10 years from now, and right now, we're talking about, just for a second, about Brooklyn, which I know something about. I mean, we got to build a new hospital in Brooklyn, believe it or not. We got to close about 4, but we got to build one new one. But when I say build a hospital, it don't mean what my grandfather would have meant when he said build a hospital. Because when I say build a hospital, I say, I don't know how many acute care beds I need in the middle, maybe not, but I think we need 5 or 6 or 7 outpatient wings that are clinics, that are freestanding, maybe even a couple that have 3 emergency room beds, and we use that modern invention called the ambulance every once in a while. And some of that kind of stuff. And really starting to figure out how to tie that in with how to tie in the electronic medical record, how to tie that all together. That's where the future has to be. Getting there is very tough. So what's going on? 2 things are happening at the same time. One is lots of institutions are trying to figure out how to do this sort of on their own within their systems. Mount Sinai is clearly one of them. And at the same time, the state, using leverage that it has from the fact that it is one of the 3 major payers with Medicaid, and with the support of CMS, the Center for Medicare and Medicaid Services in Washington, which is the federal regulatory piece who agree with this, are trying to move to a value-based paying system with different mechanisms and different approaches. And we're doing it in the state of New York through 2 things. One is you've heard the DSHR program. It's the Delivery System Reform Incentive Payment Simplified System. Right. But the theory there was to break the state up into 25 units, and they're all very different, upstate being different from downstate, and downstate ones being different. And in each of them, try to drive some program change, make each one of those 25 work on a series of program changes, which will in effect create a new set of patterns of healthcare delivery. I mean, I give you the one that there's only one that's on everybody's agenda, and it is the toughest. It's the integration of primary and behavioral care, right? We have never done it. It's insane we've never done it. It's very expensive. It's the behavioral costs in the acute care system of people who are treated one day and are back 3 days later. I'm exaggerating the days. It could be 2 days or 5 days. But the fact of the matter is that we have never done that, and how we do it and how people learn to do it and how the 2 systems start coming together to treat patients. Do they do it? I mean, and then you understand the bureaucracy and the legal problems. Do they do it in the same site? Do they need special approval to do it? You know, who is going to do the hand? Just think about this for a second. That's what's going on in the state now. It is long overdue. It's going to be chaotic. Some of it will not work, and some of it will work. And some of the programs will work in parts of the state, and they'll do it better, and other parts won't work in parts of the state, and we'll have to go through another round to change it there. But what's going on now is actually an effort to make what you do much more important, to focus on the delivery of care at the patient, I'm going to do it in business, at the consumer level, to focus at the delivery of care between the providers and the consumers, to get the providers to do more integrated care so that they work with each other, to bring into the network people who are not part of the white coat system, to bring into the network people in communities to help people in communities navigate through systems they do not really understand, to help them and make sure they actually respond to providers, to put what they used to call case managers when I was young, into the primary care system to reach out to people. At least it's not, that's my signal. So that is where we're going. And we're doing it in the face of all the history and all what we inherited before. My turn for questions. I'll answer any questions, if I can.
So thank you for coming. I have a question about the point you made where it's a little crazy that legislators are the ones determining how this works. How would you propose physicians get involved in the legislative activity around healthcare delivery?
You know why that's a fascinating question? It's a fascinating question because once upon a time, long, long ago, physicians were very involved. I mean, when Medicaid and Medicare were being discussed, actually, when Hill-Burton was being discussed, the American Medical Association, there was actually another proposal by the president at that point, which really was probably what became Medicare 20 years later, and the American Medical Association shot it down. So they were involved, you know, they were lobbyists way before most other present-day lobbyists were involved. I think the way physicians, you know, when we talk about physicians now being involved, we are talking about physician groups being involved. And the answer is, I think they are. I think they play a role. They certainly play roles in the district discussions. They do play a role with their local legislators. Remember, most of this, when you get to the legislature, forgetting a lot of the stuff which has gotten some of the legislators in trouble. But the fact of the matter is, on stuff like this, let local legislators make a difference. And the way you do it is that people, like anything else, they get involved with the legislators and talk about some of their problems, and they're doing it. I mean, we hear from I heard from lots of medical groups and lots of physician groups, you know, on both of our commissions. They were very involved.
So one of the questions to follow up on that, if you let that happen, what basically ends up happening is everybody goes to Albany with their own self-interest at heart. I mean, we've seen that with, you know, Greater New York Hospital Association. You see it with AMA. You see it. Everybody goes up talking about what's in their own self-interest. So how do you get some consolidation of those ideas that really looks at the public's best interest? Because I think that's what people were attempting to do when they set up these commissions, was to basically get out of that environment and say, let's let some people look at this whose self-interest is not directly involved in those issues.
No, what it was to let everybody whose self-interest is involved in these issues have to come together around the same table and come to make a decision. I think the difference, Neil, is that we have in the last 5 or 6 years, with the Medicaid Redesign Task Force and the structure that was put together, and now the district structure, we haven't eliminated people going and banging on their legislators' doors, but it is much less effective and has much less impact on final decisions, because those groups are all basically made up of both all the players in the industry and, not enough, but a bunch of some community folks as well. And so the stuff that was done, like the behavioral, physical health and behavioral health being put together, moving people, trying to deal with dual eligibles and all the rest, that was done because sitting around the table, everybody agreed that we had to do it. And so the legislative piece is now much more peripheral, and the end-of-year trips to Albany are much narrower and much smaller than they used to be, because by and large, a lot of it is now being done collectively. Where there is weakness in that process, and we have talked about it, is we're trying to do so much, so fast, because we're under mandates from the federal government, because they gave us some money, that the spread of competence around the state and the ability to do this is very different. And I don't know a way around that, but this time it's not special interest problems to a large extent. It's just figuring it out, and figuring it out because everybody's everybody who's in the district program, which is everybody, will have to deliver on the programs they set out in 2.5 years, or they're going to lose the money. I got to tell you, people are going to lose the money, because they're not going to make it. Some of this stuff is very tough. And I think that is the biggest issue that we're all facing now, is how to make some of this happen, given the density and the size and the complexity of what is actually not only delivering health care, but delivering it in a different way with lots of people who have never really been involved in the system.
Yes.
You're live.
Oh, it's on. Okay, thank you. Thanks so much for your talk. Question, we have all observed the rise of the urgent care centers, and you spoke a little bit about that, but can you speak about what you think the motivation is? Is it financial? Is it a community need? Like, why is this happening now?
It's financial. I think it's financial. And that doesn't trouble, by the way, that doesn't trouble me, because the fact of the matter is that if they pop up in places, I wish there were more of them able to pop up in some of the communities that need available care more than some of the places. On 86th Street and Lexington Avenue, it's not as much as I'd like to see it in Bushwick. But the fact of the matter is, it is financial, but it is providing a service. And the other thing it is doing, even in those communities, it's taking people out of the emergency room. I mean, one of the problems, by the way, you should all understand, I love you all, but you should understand that emergency room care is episodic, it's not systemic, it's necessary, there's no other choice for a lot of people, but it ain't real health. I mean, it's emergency care, it is not the kind of health care we want. So I'm not afraid of some of those. I'm not afraid of those. I'm perfectly happy to have them. I would like us to focus on changing the way, in fact, what I'd like to see is versions of that in all communities and find a way to support them.
So you talked about the districts and you talked about the empires. And a lot of the community health centers, I chair the board of one, are really worried about how the value-based system is going to actually play down when Mount Sinai, for instance, shares the savings, which are supposed to be part of the system, and whether the community health centers and other primary care providers in the downstairs street level are really going to share in those savings that they are providing.
I'm worried about that too. Look, and we're not just, you're talking about, I'm not just talking about the FQHCs, I'm talking about, and I'm also talking about some of the need to bring in some what I call the non-white coats. I mean, people on the street level to help people, function. We're all worried about that, okay? And I was saying to Neil, Dr. Kalman, a little while ago, that we had a meeting with all the upstate PPSs at the end of November, a very different set of issues upstate. But what was interesting was I had a sense, because of the nature of the communities up there, that there was much more effort to achieve spread on how it was being done. Downstate is a bigger problem. It's denser. These guys are bigger. It is harder to deal with. Unfortunately, for personal reasons, I can't make the downstate meetings, but I have got put together a list of questions. I am worried about that as well. I mean, part of the reason I'm worried about it is psychological. It's environmental. It's mental. I mean, we're telling people, and they're not, these guys, Mount Sinai guys are not bad people. They do some very good, they do terrific things. We're telling them they have to function totally differently. They have to think about stuff in ways, healthcare delivery. They have never thought about it before. Maybe they thought about it and they understand it, they not understand it, but it's not part of their genetic makeup. And so how you get people, particularly people in large institutions, to change how they behave and how they think and what's the stuff that's on the table depends upon a couple of things. First, there's a question of who's sitting at the table and who's in the room and who is yelling at them. And then how good their hearing is. All right? I mean, that is, and I think I'm worried about that also. I think all of us who are involved in trying to monitor this are very worried about that.
Yeah, this is great. Thank you. When you look at sort of the trajectory of what you're describing, a lot of this is sort of using the analogy of the emergency room. There's an urgency to all of these systemic interventions that don't really give us an opportunity to study and reflect. So I'm just wondering what your thoughts are about having the state or some organization begin to invest in an evaluation process, because this is pervasive. I mean, we have the same problem in our education system. If you look at what's going on with community and policing, I mean, a lot of our institutions don't know what to do around these crises, and I'm just wondering what your thoughts are, so that if we're doing something now with DISTRIP, what are the lessons that we can learn and study while this is going on so we don't continue to make the same mistakes?
Okay. Number one, if we do it, I want to do it inside the healthcare system, which is big enough and painful enough, and with all due respect to the other systems, it's not my valise, all right? It's too much to try to do, but the concept of we are supposed to, in DSRIP do exactly what you're talking about. There is a part of the dollars that are set aside for just that, for outside analysis and review of what is happening and what is going on. Unfortunately, we're in year 2 now, and unfortunately, realistically, not much has happened yet. I mean, most of this, as up to now, downstate in particular, has been building the infrastructure, okay? And the trouble with building the infrastructure is, you know, it's an infinite function. And so there's not that much to measure yet. But what we can measure, starting now, which is something I want to start doing, I was hoping to lead that discussion, is we got to begin to measure the issue of inclusion. That's one thing we can measure at this point. How the PPSs have been structured, who is involved in the decision-making, and that's something that we can start doing now. But the next step, and we've talked about it, is to begin to do analysis of the programs, because people are doing the same programs differently, and begin to start that very soon. I've just actually talked to the Medicaid, Jason Helgerson, about it this week, because that's exactly what we got to start doing. Because you got to trade lessons learned. If you don't, then all it is not invented here, I don't want to hear about it. And that's very bad.
Your point is well taken about the fact that we all need to start thinking differently and talking differently about healthcare. How do you think we as primary care doctors should be talking to our patients about this new system? How can we help them understand and navigate this new system?
And now I'm now crossing the line. The fact of the matter is, I think you have to spend more time explaining to people what you're doing, what's happening, and how it affects them. Let me give you I'll give you a real-world example. I'm going in for surgery on Monday. It's a big deal. I don't like surgery on me. It's the first time I've had general anesthesia ever in my whole life, and I'm 104. So, you know, it's been a long time. When I went to visit the doctor who's doing it, who was recommended by a very good friend, my wife came with me. We sat and listened to him, and when it was done, my wife said to one of our friends that night, Berger had no questions. And the guy said, it's impossible. Berger has never been anywhere where he hasn't had a question. The fact is, it was totally, I mean, I had a total explanation of what he was going to do, what I had to do, and by the way, I have that with some, I know that the present system we have almost doesn't allow the time for that. Because if you're working in a clinic, if you're working in an ER, if you're working in an FQHC, and you got people backed up the gazoo waiting to see you, that you don't have the time. And that's why the structure that we're talking about on different kinds of advanced primary care is a structure which doesn't put that burden totally on the doctor. It creates, I mean, we should be spending money on training and building administrative staff that take a chunk of that load. Can't do all of it, I understand that, but a chunk of that load to help make sure that the patient going out the door understands what just happened, understands what they're supposed to do. You know, it is, we think of, and we do a crappy job, except of course Mount Sinai, we do a crappy job on discharge. Okay, from acute care institutions. We do a worse job in the primary care system on discharge. And it's not it's just the pressure of how it works. I think that's what's got to change.
So I'm going to take the liberty of asking the last question, maybe the toughest. So, you know, at the Institute for Family Health, one of our major objectives has been to worry about health equity, to worry about all of the, you know, you must have said 6 or 7 times what communities we're concerned about, what populations we're most concerned about, even in relationship to the urgent care centers where they're being built. So it's been my contention all along that the issue of equity is totally within the responsibility of the state and the way it pays. If you continue to pay less for people who have Medicaid, then then institutions get, whether they're urgent care centers or hospitals or whatever, than people can get from private insurance, you're going to get a lower quality service and less access. We've shown that here. We've shown it in studies of every academic institution. They have separate systems of care. You know, we've divided our city up into different types of places where people have access, largely based upon differential payment. And the payment system in Medicaid is totally
Inadequate.
it's inadequate, but it's also controlled by the state. So if the state really is concerned about equity and is concerned about how we can get the same level of care to everybody, it's all within the control of how much is paid. It's how much is paid to community hospitals, how much is paid for the services that you and we believe are those that need to be sort of enhanced. And if we changed, not just changed the structure of the payment system, but how much money is paid in that payment system to make sure that those things are equitable on both sides of the aisle, so to speak, then I think we could at least improve the equity and the outcomes. So how do we make that happen?
An issue you have to face on that, which is that the Medicaid dollars are 50% state and 50% federal. And when you get to the upper payment limit, any dollars is just going to come out of the state budget if you're going to increase the rates. They're coming out of the state budget. Which brings you back to the problem we had, I mentioned before, is that when the state budget on health care, on Medicaid, is a third of the budget, and you start moving it up, to do that, you have a political situation which is very hard to deal with, particularly whether you like it or not. I mean, there are education problems, there are transportation issues, and all the rest. So you have, in the framework we're in now, the only way to do that is to raise more revenue, which means to raise taxes, and that's another set of problems.
Or to get the institutions to reduce the unit cost of the things that they deliver.
No, I'll come to that in a second. Let me come to that in a second. My discussion with the state officials has been for a long time that whether it was the Berger Commission or anything else, I said before, we can't fix it by doing the structural changes because the rates, the combination of the rates plus the no pays mean that the community hospitals can't survive. So we have to have a different rate structure. The short term, the only way to do it is what I just said, is to just take more money out of the budget, which is going to be hard to do. The argument for the value-based pricing that is made by people who are driving this, including some of our state people, is it will actually free up dollars to solve some of that problem. In the DSRIP program, there are funds which in theory are to be used as interim funds to protect vulnerable institutions in the transition process to how they do things now and how it comes out at the back end. There's a substantial amount of money. I'm concerned that a chunk of that money is just going to be used as plug money for institutions that are failing, as opposed to money for institutions that are really trying to make changes. I think one way, those are the two ways you're going to have to try to do something, but in the end, we have to create a different rate structure, which allows, and the other things, you will create different kinds of community hospitals. I mean, one of the things, a lot of them are doing stuff for revenue they shouldn't be doing, and it's a quality of care issue. So we got to really change the whole. I don't have an answer, Neil, except I know the rate structure won't work right now. I know that. And in terms of the cost, the unit cost, I said before, the real problem with the unit cost in healthcare is not the wages of people who are working in the system. It's actually the fringe benefit levels. And that's almost impossible. 65% fringe benefit level costs when the national average is 36. Assume we're more expensive in New York and we want to take better care of our people. If you split the difference between the national average of 36 and the New York average, you split it right down the middle, wouldn't have one hospital in Brooklyn that wasn't in the black. But, that's magic. And I don't know how you ever get there because the workforce issue will not let you do that. Thank you.
I think you have proven once again why it's so important to have your voice at the table, and I just want to thank you. This is, for those of you who are here who don't spend as much time in the healthcare discussions as I do at the state and federal level, I've always come to appreciate Stephen's ability to speak in a way that's more clear and to have a much clearer vision of where we need to go than almost anybody else I've ever encountered. So you've now gotten a chance to see that and to hear it, and I hope that we'll have a chance to bring you back again, and good luck with your surgery.
Thank you very much.